a quick recap. Francis is going to show, just to go through the breech delivery again. Last week, if you remember, we looked at bleeding, so postpartum hemorrhage, and we looked at the sources of bleeding and what you can do. We also looked at positions for the baby, and Francis is going to show you the just to run through the breech delivery again.
So this time I will do the breech delivery when the mother is on all fours, because we recommend that the mother should be on her hands and knees when she delivers a breech baby. So this is when she's upright, the breech is nicely sitting in there. But if we turn her over, you will notice that her back is upright and her legs will be coming down here. So with this position, the breech will be going into the bottom here, comes down this way. And again, you will see the anterior buttock first, like we talked about last time. And then you will see the crease. So the baby comes down into the pelvis. And as you see here, it will rotate round that way. And the legs will come down. One out, and then the other out. And you will also notice that the baby's tummy is to the mummy's back. So you will see the umbilical cord. And the shoulders now are sideways in the pelvis. This is really important because they need to come through sideways to the top of the pelvis. And then the baby will then start to rotate again as the shoulders come down through sideways, and a hand will come out, and then the other hand will come out. And then the head has to come through. So the head also has to come through sideways. It can't come through that way. It's got to go in sideways. So then the head comes down and again rotates. You will notice that the first thing you will see is the baby's head looking at you. The baby's face will be looking at you as the cord is looking at you, because the mother is upside down. The cord may be tightening at this stage, so just give it a little pull to loosen it. And you're now letting the baby hang so that the head is delivered more slowly. So the head will come down gradually with the weight of the baby. And this is why it's such a good position to be on hands and knees, because the weight of the baby's body will bring the head down slowly, and it will come under the little coccyx and then deliver. And then we will take the baby to mummy skin to skin. But as we said last time, this baby has had a more difficult delivery, so it may be a bit floppy and it may need resuscitation. You need to be prepared, if it's a breech delivery, have all your resuscitation equipment ready. So we will talk about that later. So are there any questions about that?
If people have questions, please use the chat function now.
We've got a hand up from Nian Hate. If you want to write, if you're able to write something in the chat, that'd be great. I'm just gonna.
Or if they want to speak, if it's easier.
Niente, have you got a question? It's okay if you want to speak.
ဒီမှာငိမ့်သေးပဲတယောက်လက်ထောင်ထားလို့လေမေးဖို့မေးမလို့လားတဲ့မေးလို့ရှိရင်တခါလေးမေးလို့ရပါတယ်ဒါမှမဟုတ်လေ message လေးပို့ထားပေးလို့ရပါတယ်
Okay, I think maybe it looks like we don't have questions.
Okay.
If anyone thinks of a question while we do the next thing, then please put your question, preferably in English, in the chat function.
Mike, I have a question. Should you sort of keep hands? I know sometimes people talk about the baby startling if you touch them during the delivery. Is there a period at which you shouldn't be touching them more or less? Or I'm just going to mute everybody a sec. And then.
That's a really good question. And last week we talked about not handling the baby too much. We want gravity and we want the birth mechanism and the mother's pushing to deliver the baby most of the delivery. Because what can happen if you pull the baby, then the baby can do sort of reflex, move its head, and the head can tip back and get stuck, or you put the head into a difficult position. So most of the time we say don't handle the baby, don't pull the baby. But if you see, maybe Francis can show us, I don't know if you can pin Francis while I speak, Lydia. If you see that the leg is not delivering easily, then you would gently use your hand to bring the leg out and help it out. And then when the buttocks and the second leg, if need be, and if the body is in the wrong position and not turning the way it should, you would gently turn, that's it. And then as the body comes, you support the body if you need to. If you feel that the body needs some support, you use your arm. So what you're not doing, Lydia, is pulling the baby, because then that head can get stuck. The head can tip back and get stuck. But you are supporting the process. It's slightly different. And if you're feeling anxious and this is a difficult situation, it is quite tempting to pull, but you have to be very strong and just support and guide.
That's great.
It must have time to turn. Doesn't have time to turn, it'll get stuck. Yeah.
Thank you.
Now here's a question from Saint-Sant. If the baby was the side of length in the ovary, what should we do?
No,
Baby was the side of length in the ovary, what should we do? I'm not sure, Saint, that you mean the ovary. If the baby, do you mean sideways in the pelvis? Please, would you rewrite your question?
Does he mean like this?
If you mean, is the baby sideways in the pelvis, what should you do? And somebody did talk about sideways position last week. Okay, we understand you now. Sant, there is no way the baby can be born in that position. If you believe the baby is sideways, the mother has to go to a hospital. That position, you can't really even turn that position. The baby will need a cesarean section. So if you suspect that, then the mother, if it's at all possible, must go to hospital. I hope that answers your question. And here's a question from Lily. Sometimes the mother doesn't give the force to birth the baby and the labour becomes long. The mother is getting tired because of the prolonged situation. That's a brilliant question and a fantastic observation, Lily. Thank you. It's true that the body uses an awful lot of energy for the labour. And if you're in the we're assuming that you're in the countryside and that you're not in a hospital, and you don't have access to drugs, in which case what you need to do is to make sure that the mother drinks plenty. We really want her to be hydrated, and she can drink water, or she can drink a sugary drink, and also to eat light food. She may vomit, but it's okay, she can still eat, and also to rest. So sometimes in labour, if things are very long and things seem to slow down, it may be that you just need to lie her down for an hour, give her some rest, keep her hydrated, and let labour come back. Sometimes, if you feel that you're nearly there and the contractions have tailed off, sometimes the better thing is to get the woman to walk and to be upright, and maybe to lean over a table, or to encourage gravity to make the contractions come. But if she's really tired and nothing is happening, then sometimes she just needs some food, some drink, and a bit of rest. I hope that answers your question. If you're in a hospital, of course, Lily, then we would use oxytocins, but we would need to be able to monitor the baby, because it's oxytocin has a strong impact on the baby. So it's not something we can use in the countryside without good fetal monitoring.
Can I ask a more question, please?
Yes. Are you Lily?
Yes, thank you. And in that kind of situation, yeah, you said that I can make dehydrate to the mother, right? And at that time, she can't. She is already getting tired, and she can't move. And is that okay if I give her to drink more water or some sugary? And how about the problem with bladder? Her bladder, because she's thank you.
Another really good question, Lily. It's great that everyone's really putting things together like this. You just have to keep, obviously you do bladder care at the same time as hydration. So if you feel, she should be urinating every 4 hours minimally. If she wants to pee more than that, that's fine, of course. But if you sense that she's had quite a lot to drink and it's been a while since she's been to the toilet, then tell her. She might be tired, she might say, I don't want to, but you have to be strong, and you say, we need to try and urinate. And actually, sometimes if she's been lying down and had a rest, and then you say, right, get up now, go and squat, go to the toilet, that movement is really good. It can change the position of the baby a little bit. It can encourage the uterus to activate and contract again. So you do both at the same time. Great question.
Thank you.
Okay. I think we're probably ready to move on to the next difficult position, which is shoulder dystocia. Francis can just show with the pelvis. I will show you a PowerPoint, but Francis can just show you. Shoulder dystocia is when the body of the baby is stuck, the head is delivered, and the body of the baby is stuck. The shoulder is stuck over the pubic bone. So the head is delivered and the shoulder is trapped behind the pubic bone. You can see that. And this is a very dangerous situation for the baby, because once the head is out, if the shoulder and the body is stuck, the blood through the umbilical cord, there's sometimes the cord will be the cord can be trapped, and the baby has only about 7 minutes before you need to get the body out within 7 minutes, or the baby is likely to be brain damaged or even die. So it's a very dangerous situation. Now, the temptation, we will go through it. I will share my screen in a minute. But when the head is out, there are 2 things in this scary situation that you want to do, but you must never, never do. That people want to do is to pull the baby's head, because they see the head and they want to pull the baby out. As you can see, is Francis pinned, Lydia? Great, thank you. So as you can see, if the shoulder is stuck, pulling the head cannot deliver the baby. If anything, it puts the shoulder more, it traps the shoulder more on that pubic bone. So pulling the head makes it worse. Additionally, pulling the head and neck will damage the nerves that go to the shoulder, and you can cause a shoulder injury, a brachial plexus injury, where the arm and the shoulder are, it leaves the baby with some paralysis in the shoulder. But most importantly, it will not deliver the baby. So do not pull the head. The other thing that you must never do, you want to do it because it seems logical, but it is very dangerous. The other thing you must never do is fundal pressure. If you do fundal pressure, as you can see, Francis is putting fundal pressure and the shoulder is getting more trapped. So these 2 things, we want to do them, they're in our hands, but we must never, ever do that. As you can see from the pelvis and from the shoulder, the 2 things that we need to do is to open the pelvis as much as we can to make more space for the baby. And also, if you, Francis, if you just hang on a moment. Oh, and also a maneuver that will push the shoulder away from the pelvic bone. So we don't do fundal pressure, but we do suprapubic pressure, so just above the pubic bone. We can either do continuous pressure with our hand where the shoulder is, or sort of pulsing pressure. So Francis, if you just do that with your hand, suprapubic pressure. So the way we open the pelvis is to lie the mother completely flat, and I'll show you a picture in a minute, and we bring her legs right up to her ears. This is called the McRoberts position. And this will open the pubic arch, so the knees right up. I will show you a picture. This opens the pubic arch a little bit more. And this is often, and brings the baby down a little bit. Now, this opening procedure is often enough to relieve the shoulder. Then you get the mother will hold on to her knees as well to have everything really open. And you say, give me a big, big push. And often that is enough to free the shoulder. So the McRoberts, getting the woman flat with her knees right up, is called McRoberts, is usually what will free the baby. Yesterday at my clinic in my hospital, I had a shoulder dystocia, and it was very serious. The woman was quite short. She was about 1.65 meters, and she had a 4.37 kilo baby. So it was a very big baby for her. But McRoberts was successful in, and then we just helped bring the arms out, which we'll show you. So McRoberts is really the best thing you can do. If that does not work, you can then do what we call suprapubic pressure. You need to know which side the baby is facing. So you need to know where the back of the baby was, which you will have done because you have palpated the woman's abdomen in labor to see what position the baby is in. And then you apply with the palm of your hand or your finger, usually with the heel of your hand. You can do either continuous pressure or a sort of rocking pressure. Okay, and what you're trying to, you are not pushing the baby down, you are trying to untrap, free the shoulder and make it move down through the arch. Now, as we said before, with every emergency, before you do anything, you call for help. Help is number one thing that you do. You will hopefully have more than one person here. So one person could be doing suprapubic pressure, one person can be with the mother and saying, come on, you can do this, push, really big push, really big push. And one person can be at the head, the baby's head, trying to deliver the baby. This is why you always need 2, 3, 4 people in an emergency situation. So if the, I think what I'll do, Francis, is share my screen now to show those pictures on the PowerPoint. And everyone should be able to see that. And then we'll go back to the doll and pelvis with you, Francis, in a moment.
Can I just say about how we know whether the shoulder's stuck?
Yes.
Or will you do that in a minute?
I was going to show it on the PowerPoint.
Okay, good.
So hopefully everyone, Lydia, can you confirm that you can see the screen?
Yes, I can see it clearly, yeah.
Great. So what you can see is here is the baby, the top left, you can see that the head has been delivered and the shoulder is stuck. So this is a shoulder dystocia. Now, the way we can predict that in midwifery, because things can happen very quickly, moment by moment, we always have to be thinking into the future if we can. And the way you predict that a shoulder dystocia may be happening is that the woman is having a very long second stage. Sometimes the first stage is very long, but a real potential indicator is that the second stage is not happening how you would expect it. And this is because the baby's head is just not coming down. If the shoulders are stuck behind the pubic bone, the head will not come down through the pelvis. And so she may be pushing really hard, but you're not seeing progress. So usually we would expect in second stage, maybe the first hour, not much is happening. The woman is, she's feeling some urge to push, but you give her an hour where she's not actively pushing. But in the second hour, if she's actively pushing, you would expect to see some progress. And if that head is not coming down, you need to ask yourself, why is this head not coming down? Is there a problem? Is the baby stuck? Especially if the mother is having her second or third baby, you would expect her pushing to make quite quick progress with the baby's head. Then the next way of identifying is when the head does deliver, the head might deliver very slowly. It might take time, and it's coming and then it's going back, and it's coming forward and it's going back, and it keeps on coming, and eventually you get the head and the chin, but what the shoulder does is kind of pull the head back. So you have what we call a turtle position, a turtle. So the head and the chin are really stuck at the head. Maybe Francis, you can show with your hands on your face how the baby's head, face and chin look really sort of stuck, like they're pulled back into the pelvis. And as soon as you see that, you will know that you have a shoulder dystocia, and you know that you have a few minutes to deliver the baby. So you call for help. Help, somebody, we have an emergency here, please help me. You put the woman, we do not pull the head and we do not push the uterus, the fundus of the uterus. You put the woman into the McRoberts position, which you can see in the bottom left corner of my screen. She should be flat. Actually, this picture shows the woman with pillows. Actually, what we want is for her to be flat. So if she has a pillow, take it away. You want her to be flat on the floor or on the bed, and her knees right up and her hands behind her knees. So knees almost by her ears. This will widen the pelvis, maximize. You can see in that picture, bottom left, you can see how the angle of the pubic bone in the left bit, the angle is a bit flatter. In the McRoberts position, the angle widens, the sacrum stays flat and the angle widens, which hopefully gives you, for most babies, it gives you enough space for the shoulder to be born. If that does not work, you can see the next picture here is the suprapubic pressure. And again, hopefully that will free the shoulder. If you have sterile, if you are able to suture and you have sterile and you have an understanding of an episiotomy, some of you may have already learnt this, at this stage, if it's possible to do suturing safely, we would consider an episiotomy. This is not an episiotomy, so cutting the perineum does not make the space any bigger, but what it does do is, if you can see my picture top right, if you need to put your hand in to the perineum to try and free the shoulder, sometimes an episiotomy will help you be able to do that maneuver. But if you are in the countryside with no sterile scissors and no suturing material, then this is not, do not use other scissors. It is not advised. But if the suprapubic pressure has not delivered the baby, then you will go in with your hand and you will do one of two things. I will show you on the picture, and then we'll go through it with Francis and the pelvis pinned on the screen. You will either try and free the anterior shoulder, so under the, you'll go try and put your hand into the woman's perineum, into the vagina, and you try and locate the shoulder, and you will try and push it away from the perineum. Now, this is very difficult to do because the shoulder is stuck, so you know that there's no room. But you just try and ease or gently push, ease the shoulder away from the pubic arch, from the symphysis pubic. If you are unable to do this, you might go under, you might go to the baby's anterior shoulder and arm, and you either try and turn the shoulders so that the baby moves away from, just changes its position, you free the shoulder, or you try and deliver the posterior arm. If you can, with your fingers, hook, I think I will stop sharing now. We don't need these pictures. Oh, actually, sorry, the final picture before we go back to Francis if all of these maneuvers fail while the woman is in McRoberts, then you want to put the woman into the all fours position, get her to open her knees as wide as she can, and you try and deliver the baby in the all fours position, because again, you are opening the pelvis. So first of all, you lie her flat, knees in the air, McRoberts position. If the baby does not come, then you turn her over, you get her onto her hands and knees, and you try and deliver the baby that way. So you have in your mind, make the pelvis bigger, open the pelvis. That's what you're trying to achieve. Now, so we're going to pin Frances, and hopefully you can see her now while I talk. If you have not been able to move the shoulder, to rotate the shoulder away from the symphysis pubis, what you can do, and it can be quite successful, is to find the posterior arm. So you go in under the baby's head at the posterior part of the perineum, and with your fingers you're trying to hook the baby's elbow, find the baby's arm, and deliver the arm. And if you've done that, you instantly change the diameters of the shoulder. They go diagonal because you've got one arm out. So as you can imagine, instantly the mechanics of the baby's shoulders have changed, and that will free the baby's arm. So then again, you ask the mother to push. If the baby is stuck, quite often the body can be quite big as well. So you may still need some big pushes to bring the baby out. But once the shoulder is free, the baby's soft tissues will deliver, should follow. So we'll just do that again. You're going to go in to the posterior part of the vagina. You're going to locate the baby's arm, and you're going to gently, you might hook the elbow, you might find the elbow, you might find the hand, and you're just trying to sweep the arm and the elbow and get the baby's arm out. And as soon as that happens, if you can imagine, if you rotate your own arms, when we move our own arms, our shoulders always change position, and that will shift the shoulder of the baby. So then you ask the mother to give some big pushes, and you will still maybe need to help, but at this point you can take the baby and you deliver the baby. Now, 2 problems are likely to follow a shoulder dystocia. Because the labor has been long and difficult, the baby will be affected. The baby will look pale, will look floppy, will probably not breathe. So this baby, as soon as you identify a shoulder dystocia, you need to be prepared. Do you remember I said we always have to think into the future? So we need to be prepared to resuscitate the baby straight away. Okay, so we have to be quick in this situation with get our towels, we'll go through it in a minute, but we want to stimulate the baby and we have to be prepared to help the baby breathe. The other bad situations that will come from a shoulder dystocia, because the labor has been long and difficult for the mother, the uterus is likely to be very tired and will not be contracting effectively. And if you remember from last week, when we do not have effective contractions, the likely outcome is a postpartum hemorrhage. The uterus is tired, it's not squeezing down and closing off all the blood vessels where the placenta is, and therefore the woman is likely to bleed. So we need, thinking into the future, to be ready to resuscitate the baby and also anticipate a big bleed. And if you are the nurse who's been supporting this woman, you need enough help around you to manage these 2 people. And you also need to say to them, we need to be prepared to resuscitate the baby. We need to be prepared to manage a hemorrhage. Okay, so those are the 2 things. Is there anything, Francis, that I've missed? Is there anything you want to recap? And also, can we have questions in the chat box, please?
You must always remember that actually when the shoulder is caught, we have bony pelvis and bony arm. So you cannot make a bone move against a bone. So it's really important to visualize the fact that this is stuck because you've got one bone against another. Okay. I think that's everything, Mike.
I think maybe, Francis, if we just if we summarize it again, we'll just recap so that we can just visualize it. So we've had a woman in a long labor. She's been and that baby is
very slow,
very slow, goes back, a slow progress. You're thinking, why is this head not coming? Why am I not seeing the head? And yesterday in my shoulder dystocia, the woman pushed for 1 hour and 20 minutes. She pushed really hard and I did not see the head. So I was suspecting that this baby would get stuck. So the baby has, she's come, and eventually the head comes and it does what we call a turtle. So the chin and the head are delivered, but the perineum kind of pulls the head back in, and the head is really tight on the perineum, and the baby does not turn as you would expect it in normal labor. The shoulders restitute. This does not happen. So first thing, what do we do in any emergency?
Help!
Okay, help! Okay, so I come running in and I say, Francis, what's the matter? What do we need to do?
I think the shoulders are stuck. Can you help me?
Yes.
Please get ready to resuscitate the baby, and please get ready in case this mother has a bleed.
Okay, Francis, I will put my equipment out very quickly. Now what?
The baby is still not coming, so we must lie her flat.
Okay, we will put her into Robert's position.
Lie her flat.
Okay, so Mrs. Brown, please would you lie flat, and we need to put your knees right up by your ears. Open the pelvis as wide as we can to make room for your baby. So the mother is now in Robert's position. Is the baby coming, France? Come on, Mrs. Brown, push.
No. So can you help me now to push the shoulder over?
Okay, so I'm going to use the heel of my hand and I'm going to do suprapubic pressure. I'm going to rock because I want to move that bone away from the bone of the mother. I'm not pulling, I'm not pushing on the fundus, I'm just trying to move the bone, okay? Because if I push on the fundus, I can cause danger to the uterus, I can break the uterus. So it's suprapubic pressure. Is the baby coming, Francis?
No. So I'm going to put a hand in and try and turn the shoulders. Please, can you listen to the baby's heartbeat to see if the baby's okay?
Okay, I'm going to use my pinard stethoscope and I'm listening. Boom, 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 boom. It's a bit slow, Francis. I think this baby is tired, needs to come out.
So I'm going to put my hand in and try and get the posterior arm out. Oh, good. I can feel the arm. So I'm supporting the arm out. Oh, wow. Push now. Push.
Mrs. Brown. Oh, it's coming. It's coming.
Oh, it's out.
He's out.
Is my baby all right? It looks a bit pale and floppy.
Okay,
I'm
Francis,
not looking good. It's not crying.
this baby needs help. This baby needs to be resuscitated. Can we put a hat on the baby and rub the baby? And in a minute, we will talk about resuscitation. There we go. We'll show you a full resuscitation with the PowerPoint, but that is the shoulder dystocia. And you can see, even on the internet, how Francis and I can work together as a team. We must never, ever, ever be ashamed to ask for help, okay? We want to work as a team and we want to know the same procedures and the same maneuvers, but we want help. Childbirth is not something we do alone, and difficult births especially are not something we do alone. So we always ask for help and we always work with each other, suggest what we do next, ask questions. If you think the other person has missed something, again, there's no shame in saying, oh, Francis, should we do McRobert's position? Should we get her flat? Have we tried suprapubic pressure? There is no shame in, we can work with each other without saying, oh, I think you've missed the McRobert's position. Surely you need, we don't have to be rude. We can work together collaboratively, and we must work as a team in an emergency situation. So are there any questions? Does somebody want to write in the chat box the 2 things that you must never do in a shoulder dystocia?
Or a breech birth.
Or a breech. What are the 2 things? Let's have a look. Okay, there's a good question here. Never pull out the head. Brilliant. So we never ever pull on the head because we can cause a brachial plexus injury. We can cause paralysis in the arm. It damages the nerves in the neck. And what was the other thing that you must never do? Do not give fundal pressure. Brilliant. Pyfo, lovely to hear from you. We must never do fundal pressure. This is because all it does is push bone on bone more, and also really strong fundal pressure can break the uterus, and that will just kill the mother. So, and we've seen fundal pressure in Myanmar. We've seen it around the world in the other places we have visited, but it is really dangerous, and it will not help because all you're doing is pressurizing bone onto bone and making it worse. Great, so those are the 2 things. There was a question here after the delivery, how do you clean the area of the vagina? So that's a really good question. And we will talk about care of the perineum after the delivery in either the next session or the session after. But basically with clean water and towels, you will wash the vaginal area. You do not have to go inside the vagina and do anything. If you are satisfied, do you remember we said you have to check the placenta? If you are satisfied that the placenta and the membranes are complete, you will just wash her down with clean water, clean towels, or a clean laundry that you can wash. And then with good light, so you might need, if you have a torch or daylight, you will examine the perineum, you look at the perineum, and you look for bleeding. There will be some bleeding, of course, normal bleeding, but you are going to look for tears. If you have suturing material with you, you might suture, and you are able to, you might suture the perineum. If you do not, if it's a fairly simple tear, if it's not too big, and you can push it together and it stops bleeding, then you can just use pressure, get a pad, get a clean longy, put it against the vagina and tell the woman to keep her knees together, and that will pressurize the perineum into healing. If it's a serious tear and it involves the anus, then she will need to go to a medical facility for proper suturing. If it's involved the anus, she will have bowel problems, she will have bowel incontinence if it's not properly sutured. Here is a comment from Lily. I had that kind of bad experience 10 days ago, and question, was it wrong to give fundal pressure? It is wrong to give fundal pressure because you know, we must not feel bad about what happened in the past, because what happened in the past is behind us and we didn't have that information. But fundal pressure is dangerous. Sometimes people do it and it looks like it works, but it is so dangerous because it can rupture the uterus, and in the case of a baby being stuck, it can push the shoulder more onto the pubic bone, not less. So we do some pressure, but we have to apply it in the right place, and that is on the shoulder, near the pubic arch. And we can do some rocking pressure, but if you push the uterus right down, you know, and the baby, you are applying too much pressure onto the uterus and it can be damaged. But was the baby okay, Lily, from that experience?
Yes, fortunately, the baby cried immediately after the birth, but that's a long, prolonged labor.
Yeah,
so I was really concerned with the baby, both baby and mother, but the mother didn't want to go to the hospital. So we tried together, me and one midwife there with me. Yeah.
Great. Well, I'm glad it was a really positive outcome, and hopefully you, in your future, your practice will change a little bit from fundal pressure to suprapubic pressure in the case of a shoulder dystocia. Thank you for sharing that. It's really good when people, you know, positive experiences are great to share, but negative experiences we can all learn from. So thank you for your courage to...
Shows courage, yeah.
Any other questions on a shoulder dystocia? Okay, in that case, I think we will move on to our last emergency, which is a cord prolapse. Sorry, I just need to share my screen. So I'll share the screen, Francis, and show it on the PowerPoint, and then we'll go through it with the doll and pelvis. Or do you want to?
No, that's fine.
So a cord prolapse, you can see here, is when the cord comes in front of the baby. This can happen when, if the baby's head is very high before labour and the waters, the membranes rupture, the cord can slip down. Or sometimes it even with a head that's not too high, the cord can come into the way. Obviously, if the head is really low, then there is no more room for the cord to come down. But the other situation where the cord can come down before the baby is in the breech position. In the breech position, you're more likely to have a cord prolapse because the bottom or the leg do not fit completely, do not fit as evenly, if you like, into the pelvis. So there might be space for the cord to come down. Now, a cord prolapse, you might see or feel something soft and strange in the vagina. And you're thinking, what is that? What is that thing? That looks very unfamiliar. And as soon as when you have a question in your head in midwifery, it's really good to give yourself, to keep going with that question. Usually when we have a funny feeling, an instinct, those things are right and we have to act on them. So you think, oh, what is that? Now, then you have to investigate and you look and you will see a sort of whitish, pinkish cord, and it looks and feels different from the vaginal tissues, from the perineal tissues. As soon as you see that, you know that if that cord is compacted, if it's squashed when the baby's head comes down, it will stop the blood flow to the baby. So it's very dangerous. And so what we want is to make sure that the cord sort of stays warm and moist, and that the baby's head stays away from the cord or the presenting bottom. So what we want is to get the mother's bottom into the air so that gravity encourages the baby away from the vagina, away from the perineum. And we might, so we want to replace the cord into the vagina, and then if necessary, we push the baby's head away from the vagina until you can get help, or if you think that she is fully dilated and she can push that baby out quickly and you are not able to get to a medical facility, then you might have to say to the woman, this baby will die if we do not get the baby out really quickly. So you have to push as hard as you can. So we have to get that baby out in a few minutes. Once the baby's head is on the cord. Obviously, if the head is not on the cord, then the blood can flow freely and there's no problem. So if you identify a cord prolapse, we push the cord into the vaginal tissues to keep it warm and moist. So it will, but we do not handle the cord too much because we don't want to cause any kind of spasm. But we just gently put it back into the perineal tissues to keep it warm and moist so it keeps working effectively. And then we need to get the presenting part. We need to make sure there's no pressure on the cord until the baby is absolutely ready to come out. So until she's fully dilated. So we get her bottom in the air and we get, if necessary, we put our fingers in and push the presenting part away. If you are in the countryside and you are not going to be able to get to a medical facility, then the only thing that you can do in time is, when the woman is fully dilated, is to have as fast a second stage as you can, because we don't want this baby's head pressurizing the cord any longer than it has to. And then, of course, once we've got the baby, that baby will need resuscitating. So we need to be absolutely ready with resuscitation. Maybe we need to think through the steps of resuscitation before the baby arrives. If that baby comes slowly and we're in the countryside and we couldn't get her to a hospital, then sadly that baby may well die in the delivery with a cord prolapse. But we did everything we could to help that baby. So, we know that some babies die, and in a situation where we can't get to a hospital, then we've done our best, and then we look after the mother and we do the other steps as normal. We deliver the placenta as normal and we look after her as normal. So Francis, can you just show on your pelvis, because now you're on the big screen. Do you want to talk it through?
Sorry. You can see now that this head is quite high out of the vagina, out of the pelvis, and the cord during the labour has slipped down beside the head. And because this is a bony structure and the head is bony, then there'll be a lot of pressure on the cord from the head. You can see this is going to be a big problem. So if you see or feel a cord and it's coming out of the vagina, then just pop the cord gently back inside to keep it warm, but don't push it so that it's tight. It must just lie in the vagina to keep warm and moist. And then turn the mother over so the head goes back and her bottom is in the air, and it'll come away to relieve the pressure on the cord. And then if you know that she's fully dilated, you need to get this baby out as quickly as possible so that there's not too much pressure on the cord. Otherwise, she needs to be in this position to take the pressure off the cord until she eventually gets to fully dilated, if that's possible and you haven't managed to get her to the hospital. But as Mike has said, you've done your best in this situation, and it's very, very difficult for the baby because unless you can get the baby out fairly quickly, it is not getting enough oxygen, and therefore there'll be possibly damage to the baby or it might die. Okay.
Sorry, Michael, you're just muted.
Happens all the time, doesn't it? Are there any questions about cord prolapse?
There was just a question in the chat about needing whether to do an episiotomy or not.
Episiotomy.
Episiotomy, that's a really good question. Thank you. I think it again, it depends where you are. If you are, so episiotomy in my country, in my hospital, we only use an episiotomy now to speed up the delivery. So logically, an episiotomy might help speed up the delivery, but we would still only do an episiotomy when the perineum is quite stretched, so the baby's head is already quite down, the head is coming out and already stretching the vaginal tissues, and we could, that could speed up the delivery of the head. So it is worth thinking about. But if you are in the countryside and you do not have sterile equipment and you are not, you haven't done much suturing, then you have, you risk a difficulty for the mother. You risk infection if you haven't got sterile equipment. Maybe she can reach a medical facility later for suturing, but so it might help, but it will do damage to the woman if you cannot adequately, if you cannot successfully sew the tissues, in a sterile and clean way. So it might speed up the delivery.
And also, if you do it before the head is right down on the perineum and it's stretching tight, if you cut it too early, the mother can bleed very heavily from the episiotomy because there is no head there to stop the bleeding. So you should only do it, as Mike has said, when the head is right down and stretching perineum, because otherwise the mother will bleed a lot from the episiotomy. Okay.
Thank you very much, Dorche, and please, all questions, as Lydia said, all questions are good questions. Questions show that people are learning, so it's great for us to have questions. And also, when people have the courage to ask a question, you should feel reassured that often you're not the only one thinking that. And so questions are a way of sharing. So thank you for that. Do keep questioning. I'm just going to show you the last slide of this presentation. And it's just really, to remind us to care, you know, what we do after an emergency. So we've had a difficult delivery, we maybe have had to resuscitate the baby, but we're happy that the baby is now breathing and looks a bit more awake and is moving its legs and arms, so it has good tone. Maybe the mother bled and we had to you know, we had to do some fundal uterine massage, or maybe even some compression to stop the bleeding. So we've had some difficulties, and now what we need is some peace and quiet and rest, and we need to stay with the mother, or we ask somebody else to stay with the mother who can observe the mother and the baby. So we take her pulse, we take her temperature, we take her blood pressure, we do the normal observations. We wash her, we settle her down with clean bedding. We want to give her maybe some light drinks. She needs rehydrating, but we don't do too much too quickly because she might vomit. So some light drinks, some light food, and lots of rest. And we put the baby, we put the baby skin to skin with the mother under a blanket. Maybe the baby needs a hat still. We always put a hat on at the delivery because a wet head can the baby can lose heat very quickly through their head. But we do skin to skin, which will help with the breastfeeding, and it keeps the baby warm, and also it reassures the baby. It helps stabilize the heartbeat. So now we've had our emergency, we've had lots of noise, we've had lots of talking. Now we need to have peace and quiet. We need to observe the mother, we need to observe the baby, and we need to hydrate the mother, give her rest. We need to feed the baby and give the baby rest. And again, we've talked a little bit about documentation. We want to sit down and write down what happened and what we did, because we might need to report this to the next person looking after her, or we want to remember what happened with this woman in case she has when she has the next baby. Sometimes these patterns repeat. So it's good to know, with your last baby, what was your labour like? Did you have any difficulties, and so on? So we write down what we did. And that's how we care after an emergency. And for the next few days, especially if she's had a bleed, she will feel weak. She'll need some extra, she'll need extra care. We would visit, go and see her maybe once or twice a day, and just see how she is, and keep taking her temperature and pulse and blood pressure to make sure that her observations are normal, and that there are no signs of infection. Okay. The next, unless there are questions on that, we wanted to talk to you about listening to the baby heartbeat, and also helping a baby breathe. So Francis, do you want to do the heartbeat?
I think that's probably, I'll do the resuscitation actually.
Okay.
So,
okay, I will, what I'll do then is get my, actually I don't want to do that, sorry. I will find the slide.
I've got it here, Mike. I'll do it and you can chip in.
Okay, but let me just get it up on the screen. Being a bit slow now. Right, so I'm going to share my screen now. Go. Okay.
Okay, so we're going to talk about listening to the baby's heartbeat, and we usually listen to the baby's heartbeat with what we call a pinard or a stethoscope, or sometimes if you have one of these double stethoscopes here, you can listen to it on the mother's abdomen with that. Okay, so why are we listening? We're listening to make sure that the baby is okay, that it's coping with these strong, long contractions, and that it is happy and the birth is going well. If we don't listen to the baby's heartbeat, then we have no idea whether the baby is coping and is a happy baby, or whether the baby is not coping with the birth. We also need to, when we're listening to the baby's heartbeat, feel the mother's pulse. Now, the reason for that is that if a mother is in labour and struggling with the birth, sometimes her heartbeat can be almost the same as the baby's. It can be quite fast. So if you feel her pulse, then you will know whether you're listening to the baby's heartbeat and if you feel the mother's pulse, you'll be able to know whether you're listening to the right heartbeat, okay? So it's really important that you decide which heartbeat you've got. So it's something you need to practice. So antenatally, when you're caring for mothers, practice this so that you can find the heartbeat easily and you can feel the mother's pulse. And another reason why you need to know where the back is and which position the baby is in is you will then know where to listen to the heartbeat. The baby's upright and head first, you will hear the heartbeat here. If the baby's a breech birth, you will listen to the heartbeat up here. So it's really important before you even start to listen to feel which position the baby's in, how far the head is down into the pelvis, and how far the baby's head is down into the pelvis and which position it's in. Okay, Micah. I'll get another thing there.
Sorry.
Okay, yeah.
Okay, hang on, I'm on the wrong page. There we go.
So when should I listen to a baby's heartbeat? You should listen to the baby's heartbeat all the way through the first stage and listen between contractions every 30 minutes. You can see in this picture that there is a contraction and it's coming and it's peaking and then it's going down and there is a rest between contractions. So between the contractions, you need to listen for 1 minute, all the way through the first stage if possible. In early labour, maybe you won't be listening to it quite so often as the mother is upright and walking about. She's maybe doing a few jobs, she's going for a walk, she's active. But as the first stage progresses, you need to listen frequently so that you're sure that this baby is happy with the contractions and coping with the labour. During the second stage, you listen to every 5 to 15 minutes after contraction. And sometimes you listen as a contraction is coming or going away. So you can see in the picture that the contraction is rising. You can listen before, you listen as it's rising, and you listen afterwards. And this is so that you can see whether the baby is coping with a contraction. If the baby's heartbeat does not pick up to a normal rate after the contraction, then you know that the baby's not coping with it. So we need to think now, what is the normal for a baby's heartbeat? So how do I know the baby is okay? You count the heart rate beat for 1 minute. So it's good to look at your watch, if you have a watch or a clock, to listen for a whole minute. So a good happy baby's heart rate is 110 to 160 beats per minute. And it's really good at the beginning and during that early part of labour to really identify what is normal for this baby, because each babies have slightly different heart rates. Sometimes they're slightly lower, sometimes babies' heartbeats are slightly higher. So it's good to get the normal for that baby. And the normal base rate we're going to say is 110 to 160 beats per minute. If the baby's moving about, which they will do, and it's the same way, in fact, that if you are running or moving about, sometimes your heartbeat will go up. So if a baby is moving a lot and wriggling about into a good position, sometimes it'll go up to 170 beats a minute. So the base rate, the bottom rate of the heartbeat, the normal heartbeat of the baby should stay the same all through labour, okay? So you can see in the picture that the normal heart rate is boom, 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 and then it'll go up a bit, boom, 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 boom. And that is good because it's a reactive heartbeat. The heartbeat should vary a little bit all the time, because that means that the baby is active and reacting to the contractions. If a baby is not okay, the heart rate will be below 100 and staying slow after contraction. So a slow heartbeat. And if this happens on more than one occasion, then it's staying slow even after a contraction. It's not picking up. And it's just staying slow. Even if you change the mother's position, because sometimes if the mother's lying flat, there can be pressure on the placenta and the cord. So this pressure can slow a heartbeat. So if you get a mother upright, then the baby's cord becomes freer and often the heartbeat will pick up. So it's really important, if you find that a heartbeat is slowing or becoming very, very fast, to change the mother's position, because this will often improve the baby's heartbeat and the baby will be happier. Too fast a heartbeat is above 160 and staying fast after a contraction and for 30 minutes or more. So it's really important that you're timing the contraction, counting the beats, so that you are aware of how this baby is during labour. Okay, Michael. So how do we listen to the baby during the first and second stages of labour? So we can listen to the baby, the mother lying flat. Okay, and if we hear that the baby is slow, then again, we will get them upright. And as you see in this picture, poor blood flow from the placenta is bad for baby. So if the mother is lying flat, there will be sometimes pressure on the cord. And the baby's heartbeat is slow, then you must change position. And you can see we've got the mother flat here, and then we've turned her over onto all fours. And then we're going to do her pulse and blood pressure to make sure that everything is okay for the mother. Okay, so fast heartbeat. So why do babies sometimes have a fast heartbeat? That's 160 or more is a fast heartbeat. So take mother's blood pressure and temperature. If the mother's temperature is raised, and you all know this as nurses, then the pulse tends to be raised. And that means that the baby will also feel the mother's temperature raised, and the baby's temperature will be raised, and therefore that baby's heartbeat will rise. So it's really important to take the blood pressure, the pulse, and the temperature, so that you know the condition of the mother is good. Fast heartbeats also happen when mother's dehydrated. So give her things to drink, water, and get her upright. So if a mother or baby has an infection, that will raise a heartbeat. And sometimes babies in utero, inside the uterus, if, for example, the waters have broken for a long period, then the baby can get an infection because the infection can travel up through the vagina into the uterus because the bag of waters have broken and there is a higher risk of infection. So if this happens, the baby's heartbeat can be raised. And again, if the mother is bleeding during the birth, maybe the placenta is starting to come away a little bit, the baby's heartbeat again will compensate for the lack of oxygen by beating harder. And also in a long labour, if a baby is getting tired, you know yourself, if you're very tired and stressed, that your heartbeat will rise. And it's the same with the baby. If the baby is stressed and not coping with the labour, it's a very long labour, it's getting tired, the mother is tired, then the beat will become faster. So if the heart beats faster for 30 minutes or longer, or very, very slow, so if the heartbeat is very fast or very slow, change the mother's position and also explain to her what is happening and why she needs to get off her back and upright. And at this time you will call for help because you know that this baby is going to need some help with breathing after the birth. And you need to get the baby delivered as fast as possible. So if you're worried about a baby's heartbeat, it's really important to either try and take it to hospital so that the labour can be monitored better, or if it's impossible and you're in the countryside and you can't get to hospital, get the mother upright and hopefully the labour will progress more quickly when she's upright. If sadly a baby does die, again, it's better to get the mother to hospital so that the delivery can happen as soon as possible. It's really important all through the process of labour that you write down, because if you're listening to a heartbeat, you can't remember what the first one was. So as soon as you attend a mother in labour, then write down what the baby's normal heart rate is. If you've got a record of all the heartbeats, then you can more easily see whether this heartbeat is getting faster or is going too slow. And also you'll write down a little statement of whether the baby is coping with the labour. Is this heartbeat returning to normal after a contraction? So as the contraction peaks, it will slow a bit. And as the contraction goes away, the heartbeat should return to its normal rate. And you need to write that down in your documentation so that somebody else, if they come to help look after you, look after the mother, knows exactly what's gone before. And if you're worried about the heartbeat, call for help. And as again, we've always said, get the mother upright. And it's really important that you document all this the way through, because then you can look back and decide the care of the mother. Okay, Monica. Okay.
Are there any questions? Does anyone want to write anything in the chat box?
Can I ask them if they have pinards? Have they access to a pinard to listen to baby's heartbeat?
Do you want to just put your hand up?
Do you have these?
If you have, or react, if you have a pinard. No.
No. So can they listen to, do you listen to a baby's heartbeat? Do you use a stethoscope? Yeah. Lily, you're nodding your head.
Yes, because in like a recent case, that was in my village, and I do have nothing at the time. And fortunately, I have stethoscope, so So I use it to
Yes.
listen the baby heartbeat. Yes.
Okay. And are you sure it's the mother's, the baby's heartbeat? Did you also feel her pulse to make sure it wasn't the mother's?
No, I didn't. I didn't do that.
Okay,
Yeah.
so now you know. Good.
Yes, thank you.
So anybody else has used these?
So this stethoscope is slightly different, Francis. If
Yeah.
you show, so the fetal stethoscope is slightly different. It has two ends, and it just because obviously the fetal heart rate is inside the mother, it's a bit more difficult to hear. But if you have nothing else, you can try with a normal stethoscope and just see if you can hear it. It will be very faint. Or if you have access to a pinard, you can try using a pinard. With a pinard, you will palpate the mother's abdomen to find the position of the baby, and then you're trying to listen sort of on the baby's shoulder, on the baby's in the kind of the middle area of the baby. And it's important with a pinard, if you do have the opportunity to use a pinard, that you need to press the cone slightly into the mother, so quite firm. It doesn't want to be sort of just sitting there, in a little bit, and then you let go of the pinard. No hand on the pinard, because that will affect how you hear it. So you let go, and the heartbeat that you hear is almost like a movement in your ear. It's not it's a slightly different sound from using a stethoscope. It's almost like the air is pressing in your ear, but you can, it's very difficult to do when the woman is very large, but if the woman is of a normal BMI, a normal weight, and you are in the right place, you should be able to, in late pregnancy, you should be able to hear. And it's very good if you think you have a breech baby. It's quite good for identifying the position of the baby, because your pinard will be quite high on the uterus, on the fundus, and you'll be thinking, why am I hearing a heartbeat up here? And it helps you think, oh, maybe this breech, maybe it's because the baby is sitting up and not head down in the pelvis. You won't hear it, as Francis is showing, you won't hear it lower down, because that's not where the heart is. So we've looked at identifying a normal heart rate, and counting can be quite difficult over a minute. So it's quite good to practice. If you use your mobile phone, you could, you know, on YouTube, you can set like a metronome, and you can get into the habit of counting for a minute. But in many situations, if you're really struggling to count, the main thing is the heart rate fast, or is it like a normal, steady, fast heart rate, in which case you can feel happy, or is it really slow, in which case you would feel that this is not right, and you want to change the mother's position, you want to speed up the pushing, you want to be ready to resuscitate the baby. But if you're good at counting, I mean, we can all practice counting with our mobile phone. We can set a metronome for 140 and get used to what that sounds like, or 80, get used to that, or 165. And you start to have a feel for what is a nice normal baby heart rate. Okay, so the last thing we wanted to do today, if people are still happy and you have time and you're not completely Zoom tired, is the baby resuscitation. Now, obviously, all of this is being recorded, so if you feel that you've you've slightly lost concentration, please, you can go back to it and watch the recording. So from Miat. Okay, thank you, Miat, for sharing. It's not a problem that you don't have questions. And it's great that this is new knowledge for you. I hope that you will have the opportunity to support women in pregnancy and labour. Now you will have some knowledge that maybe you can assist work with a midwife or even a TBA or a CHW if someone in your village is in labour. So we're going to look at helping a baby breathe. Just bear with me a moment. I'm going to get the PowerPoint up. Okay, now I just need to go on screen. Okay, so helping a baby breathe, we will always give a minute while we are drying the baby and putting the hat on the baby. We'll always give about a minute to, we'll look at the baby and we'll say, is this baby moving? Is this baby a good colour? Is this baby breathing? Is this baby crying? And we give the baby a minute to get used to or get over the birth.
Like I said, we're just not quite in full screen.
Then if after a minute nothing is happening or the baby is not changing, not adapting to life outside the womb, we need to assist the baby. Now, I hope that you will have access to a bag and mask, because this is much safer for you and also more effective. If you can use a bag and a mask effectively, it's a very effective way of helping the baby breathe. If it is an emergency and you have no materials, no resources, you can effectively support a baby's breathing by doing mouth to mouth. But this is a risk to you because, of course, the fluids that the baby has been born in could have contamination, could contaminate you. So you have to make that decision for yourself. Are you happy? You would wipe the baby's mouth, of course, but are you happy to do mouth to mouth or not? And if you're not, that is perfectly acceptable. We have to look after ourselves. In which case we would do the other things that the other maneuvers, which we'll talk about. So when a baby is born, the first thing we do is put the baby skin to the mother, and we are going to dry the baby. When we dry the baby, sorry, I'm just going to. Sorry, somebody was banging on the door. We're going to dry the baby. What that does, if you have, you know that when you wash, if you get out into the cold air with your wet skin, you can get cold very quickly. And the baby is wet, the head is wet, so the baby will get cold very quickly. So we put the baby skin to keep it warm, because it will take the mother's temperature, and we dry the baby to keep it warm, but this will also stimulate the baby. It wakes the baby up. So the first thing, lots of rubbing, come on baby, wake up, and we take that wet towel away, because again, as you know, if you have wet things on, you get cold quickly. So we take the wet towel away, we put a dry towel, and we put a hat on the baby. This is because a cold baby will do badly. A cold baby uses energy for heat rather than energy for normal breathing and things like that. So we've stimulated the baby, we've dried the baby, we've put the baby skin to skin. Again, the first thing we do if we're unhappy about the baby is call for help. Now, if this baby on the mother does not start breathing, does not start making a noise, then we may need to do a full resuscitation on the baby. This will usually mean cutting the cord, so we maybe cut the cord a bit more quickly than we would if we were happy with the baby. So we've tied the cord, we've cut the cord, and then we put the baby on a flat surface with good light, if we can find light. And we need, at least 2 people looking after this baby, and preferably a third person reassuring the mother and making sure that the mother knows what's going on. So then we're going to look at the baby. Is the baby pink in colour? In which case we know the baby's getting oxygen. Is the baby blue? In which case blue all over. It's quite normal for the hands and feet to be a bit blue. But if the body is blue or pale, we are not happy that this baby is getting oxygen. Is the baby breathing? Now, how do we check that the baby is breathing? We will look at the baby's chest. So we take the blanket away and we look for chest rising and falling. And is the baby moving? Does it have muscle tone? Is it moving its arms and legs? Or is it crying? If the baby is crying and moving, then we are sure that the baby is breathing, because they can't cry if they're not breathing. And then we listen to the baby heartbeat. Is it fast or is it slow?
So we're listening to the baby's heartbeat. Is it fast or is it slow?
So,
okay.
So with a slow heartbeat, we know that this baby really needs help immediately. But the very first thing we want to do is get air into the baby. So we need to position the baby's head in what we call a neutral position. Because we want the airway to be as open as possible. If a baby is unconscious, if you think about when you've seen somebody unconscious and you're nursing, everything is floppy. There's no muscle tone, which will compress the airway if you don't get it into an open position. So a head in a neutral position, you need to think of the nose and chin being horizontal. So the top picture here will show you the neutral position. Now, because of the occiput and because maybe the head has been slightly altered in later, the occiput can be quite pronounced, and you might put a towel, as Francis did, under the neck of the baby to support that baby's head into the neutral position. If you hyperextend the head, you will compress the larynx, the airway, into the other direction. So you will pinch it, if you like. It will be the air will not go in as easily. And if it's if the neck is underextended, again the airway will be narrowed. So the neutral position makes the airway as open as possible, which means you can get the air into the baby as effectively as possible. Okay, so we've put the head in a good position. This is just a recap. We've listened to the baby heartbeat. In this situation, when you're listening, you don't need to count for a full minute. You just need to decide whether it's fast or slow. Now, do remember, if you're the only one listening, no one else can hear that baby heartbeat. So you either need to say it's slow, or what some people do is when they're hearing it, they go boom, boom, or they go boom, 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 boom. So with their own mouth, they are saying, they are recording the heartbeat, and the other people around can then know what the baby is doing. Sometimes you're so concentrated that you forget to speak. And in this situation, you need to communicate what you're hearing, what your findings are. Okay, the very first thing we do, and most babies will be absolutely fine because they're not sick babies, they do not have a heart problem, they do not have a lung problem, they are well babies who just need that first, to get those lungs inflated for the very first time. Because of course in the womb, they've had everything through the cord. So we need to get 5 breaths into the baby's lungs to inflate them. Until now, they've never had air in them. And it's a bit like when you blow up a balloon. The first time you blow up a balloon, you need a bit more pressure to make the balloon inflate. And it's the same with the lungs. So we position our bag and mask really carefully, really effectively. We roll it up from the chin over the nose so that we've got a good seal all the way around. No air can escape. We need to seal around the baby's mouth and nose so that all the air goes into the baby's airway. And we do 5 strong but slow inflation breaths. 1, 2, 3, 4, 5. And how do we know we've got air into the baby? We know because we're watching the chest rise and fall. We're looking for chest movement. If we see no chest movement, we go back to the beginning. We reposition the baby's head, we reposition the baby's mask, and we start again. So we have to be patient. This is a frightening situation and we're trying to do things really, really quickly, but that sometimes does not help. We have to do things carefully and confidently. So we did not see chest movement. We go back to the beginning and we do 1, 2, 3, 4, 5. And only when we've seen chest movement are we satisfied that the baby got air. And then our partner, the person we're in a team with, after those 5 inflation breaths, will listen to the baby's heart rate again. So we listen. Almost always, if you've done 5 good breaths, you will hear, and the baby's heart rate will have picked up, and you will hear a nice fast heart rate because that baby was a well baby, it just needed oxygen. If you are not sure that you got the 5 breaths in, if you are not 100% sure that you saw the chest move, you go back to the 5 inflation breaths. Sometimes you're working with someone who is using the bag and mask. So if Francis and I were working together and Francis is doing the bag and mask, but I'm not seeing chest movement, it is not a criticism if I say, Francis, I don't think we've got chest movement. I think we need to try again. We have to be brave enough to say, even if it's a superior person, we have to say, I think there's no chest movement. Can we try again? And if necessary, you take over and have a go. So we need that breath in. And then hopefully we will hear a fast heart rate. If we do not hear, and again, you don't have to count for a minute. If you've got used to listening to you know, what is 80 and below and what is 100 and above, then you will be able to say it's fast or it's slow. Now, if you have got your inflation breaths in and the heart is still slow, you can try to do some cardiac massage. Although we have to say that in the countryside, if your baby has not picked up with the inflation breaths, there's a chance that cardiac massage won't help. So don't feel that you failed if the heart did not pick up. If you've got the breaths in, that's the very best you can do. But you can try cardiac massage. Most people prefer to put their fingers around the chest of the baby and put their thumbs one over the other or side by side on the chest, on the sternum. And then they're going to do 3 compressions to 1 breath. This is a 2-person job, and you would do 1, 2, 3. So quite fast to imitate a fast heart rate. 1, 2, 3. And then your partner would do a breath. So with a breathe, 1, 2, 3, breath. This is what it's a 2-person job. And you're all the time with the breathing, you're looking for chest compression. So we do 1, 2, 3, breath. 1, 2, 3, breath. 1, 2, 3, breath. And we're looking for chest movement with those breaths. And after about 30 seconds, we are looking, we're looking at the baby all the time, and then we're going to listen for the heart rate. So Frances will stop. She will listen to the baby heart rate. And hopefully now we've got a nice fast heart rate. And the bit, oh, look, the baby's crying and the baby's moving and moving its legs. It's got some muscle tone. So now we just, like anybody who's had a bit of an accident, a bit of a shock, we're going to care for this baby quite gently. We want some peace and quiet for the baby. So we're going to put the hat back on, and we're going to put the baby skin to skin to the mother, and just very quietly let the mother look after the baby, keep the baby warm. If the baby is showing some interest in food, we will try and offer the breast. If the baby is showing no interest in sucking, we might squeeze some milk off the breast and just put it on the baby's lips anyway to give the baby a bit of sugar. So a little bit of expressed milk will really help the baby, give the baby a bit of energy. And then we write down everything we do. So as we've said, there's lots of writing here, but it's nothing that we didn't say. We're listening to the baby heart rate, we're watching the chest movement, we're looking at the baby's colour, we're looking at movement. If the baby is crying, we know we can't speak if we haven't got air in our lungs. So we know if the baby is crying, that the baby is breathing. And really what we want is to encourage that baby to the point of giving a good big cry. Sometimes a floppy baby will do and we're not happy that we've had really good opening of the lungs. So we want a nice big cry, and then we feel confident that the baby is breathing well. And then skin to skin, warmth, breastfeeding. Just to talk a little bit about mouth to mouth. It is the same, exactly the same principle as the ambu bag. The only thing to be careful of is that the ambu bag, the bag and mask, has a valve, so you cannot put too much pressure into the baby's lungs. If you press the ambu bag too hard, the air will escape out of the valve. Now, obviously, with our own lungs, we could do a great big breath in, Frances, and then blow all that out. Now, that's much too much for the baby. Thank you, Frances. So we just need a little bit of air, just enough that we hold in our cheeks. So we inflate our cheeks, and then we want to put our mouth over the baby's mouth and nose. So again, we're making a complete seal. We're putting the head in the neutral position, and out of the side of our eyes, we're looking for chest movement. And then we do the same thing, 5 inflation breaths. 1, 2, and it's difficult to see on the screen, but Frances will know if she's it. There we go, we can see some chest movement. 3, 4, 5. And hopefully the vast majority of babies, as soon as they've got some air in those lungs, as soon as those lungs have opened for the first time, will start to move, will start to pink up, and will start to breathe. And once you're satisfied that your mouth to mouth has helped, it's a good idea to wash the baby's mouth and face from any contamination that you might have, and obviously give your face, maybe rinse out your mouth and spit the water out to minimize the risk of any viral contamination that you might have had from the baby. And as we say, this is a personal choice. You should not feel guilty. We are all women and men with our own lives, with our own families, with our own children, and we must make sure that we feel safe doing what we're doing. If you don't feel safe, you do not have to feel bad that you didn't do it. But the mouth-to-mouth principle is the same as the bag and mask. Okay, and so the last sort of idea is, if the baby is not breathing after 10 minutes, you have really done your best, you have done everything you can, and that baby is really technically dead. So you need to stop then. And again, you should not feel bad, because what you've done is the very best that you can do. And then we just care for the mother, and we talk with the mother and tell her what we did and what we tried. And, you know, very sadly, the baby has died. So, and again, as we've said with everything, we will write down afterwards, we will document afterwards all the things that we did. So that we've looked today in terms of the baby, we've looked at the baby, we've looked at normal heart rate, we've looked at when the heart rate is not normal in labour, that we should anticipate a resuscitation. We've also looked at breech and dystocia, shoulder dystocia, and again, because those are difficult situations for the baby, we should anticipate that the baby will need some help to breathe. Frances, do you want to add anything, or are there any questions for the chat box?
Perhaps if the baby's got meconium, if the baby's got thick meconium and the baby's crying, then there's no need to suck the meconium away. Just wipe it out, maybe with a cloth, clean the baby's mouth out. But if the baby's crying, then there's not a problem. If the baby's not crying and there's thick meconium, and you cannot get the baby's chest movement, you can use a little nasal suction. You squeeze it. Sorry, I should take it out of the thing. So you squeeze it and pop it to the baby's nose and let it draw it out. And again, and a little bit in the mouth. And once the baby starts to cough, then maybe it'll clear it itself. But if it's still not breathing, then you need to start your mouth-to-mouth or your bag and mask. But we don't recommend that when the baby's first born, that you suck a baby out. A normal healthy baby does not need suction. We do not need to clear the airways. It will do it itself. These need to be washed carefully after use and sterilised if possible. So does anybody have a bag and mask or a little suction thing? Do you have access to these?
Okay, so it's very difficult for everybody. We really understand how difficult it is for you. The main thing to remember, to feel confident about, is that the 99% of babies will breathe when they're born. Sometimes they come out looking a little bit shocked, their eyes are wide open, they look a bit pale, and you just need to wake them up a little bit. Dry them, stimulate them. Come on, baby, wake up. It is like waking up someone who's semi-conscious. You've done that in your nursing, or you've done that in your communities. So wake up, baby, wake up. And we want that baby to be dry and warm and put a hat on. And 99% of babies will breathe if you do that, okay? So you just keep stimulating them. Sometimes, even if you don't want to do mouth to mouth, if you just blow really hard on the baby's face, out, you know, you've stimulated them and you blow really hard. Again, sometimes they will do that reflex and it will just help them to get going. They just need waking up because they've had a bit of a shock or they're a bit tired. So we know how hard it is for you. We really, really do. But you can only do the best you can. But you can trust that nature and some stimulation usually will support the baby, and always skin to skin. Even if the baby is very pale and floppy, skin to skin with the mother can regulate the baby's heart rate, can help to support that heart rate. So those are the things that you can do if you have no other equipment. Okay, you've all been incredibly attentive, very, very patient. Yes, Lily, thank you. So you don't have the equipment now that you had in the hospital. That must be really hard to know that you've got stuff that you can use, but you don't have it available at the moment. So we really understand, and we really feel heartbroken that it's so difficult for you. Of course, you will get the PDF files. I will send them to Marcus, so maybe next, actually I think this is I'll send them to Marcus and he can put them up. Obviously there's the recording which will go on Facebook. We have a film clip which shows a resuscitation, and I think we've done enough now. I'm going to put a link to the film clip that we would have shown you today on the chat. You can have a look at that. It shows a resuscitation, really nice resuscitation. And I think we probably might start next lesson with that to recap on today. So we'll get the PDF to you, Gregory, and everybody, but it may not be today because I'm not very good at that and Marcus is away this week. There's a film clip for you to watch. Are there any other questions, anybody?
Just to stay on this Global Health Media website, there are lots of really good videos, and there's quite a few in Burmese as well, and so I think some in Karen as well. So if you want to look through it, go through it, and there's lots there.
In that case, I think we will finish today. You've been brilliant. It's been lovely to see you. And we look forward to seeing you all next week.
Michael and Francis, thank you so much. That was brilliant.
Good.
Thank you for all your questions, everybody.
Everybody have a good week, and we'll see you next week.
Okay.
Bye.
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 Bye, everybody. Bye. It's a real pleasure, everybody. Thank you for your thank yous, but it's a great pleasure. Okay.